Edel
Thank
on
you
her,
very
will I mention your title?
No.
I'll leave that to yourself. Thank you very much.
Thank you very much for the lovely introduction. So, as said, I'm Dr. Edel McDermott. I'm a consultant gastroenterologist. I've actually just relocated to St. Vincent's in Dublin recently, so that's where I'm now based. The title of my talk is quite lengthy, so I just shortened it to E-Health and Inflammatory Bowel Disease. So the overview today of what I'm going to speak about is I'm just going to introduce inflammatory bowel disease. I'll talk about some service requirements in IBD. I'll mention national standards, and then I'll talk about e-health and inflammatory bowel disease. And the specific topics that I'm going to mention is an electronic patient portal known as MyChart, the infliximab pathway, home fecal calprotectin, and new patient information evenings. And then hopefully have plenty of time for questions. So inflammatory bowel disease, so namely ulcerative colitis and Crohn's disease, are inflammatory conditions of the gastrointestinal tract. And the typical symptoms would be bloody diarrhea and abdominal pain. And these affect approximately 40,000 patients in Ireland. In the worldwide prevalence, what we can see is that the Western countries here in red have the highest prevalence, and typically the further away from the equator you go, you get rises in prevalence as well. But what we have seen recently is a major increase in incidence and prevalence in the newly industrialized countries, leading to a big worldwide increase in inflammatory bowel disease. And important to look at as well is the incidence and age when this happens. So we see that this is predominantly starts in young people, but this is a lifelong relapsing remitting condition. So this is something that's rising in prevalence and starting in people in their 20s that are going to have this disease for 50, 60 years. So there's really important service implications. If we look a little bit about the patient journey, so this is actually Sinead, who I met first in July in 2012. She originally presented to her GP with bloody diarrhea for 2 months. The GP sent her in to me, and I booked her for a colonoscopy. And her colonoscopy confirmed inflammation of her colon, and she received a diagnosis of ulcerative colitis. She then came back to the clinic to meet the IBD multidisciplinary team and discuss treatment options. And this included kind of the treatment options that we have, so medications, injections, infusions, and surgery. And she was started on a medication known as mesalazine, a tablet. She then went on to have blood monitoring for her medication and continued on her patient journey. Unfortunately, she became quite unwell in January of the following year very quickly and was admitted to hospital. She was given IV steroids, potent immunosuppressants, but they were having no effect. So we had to have a discussion with Sinead about what kind of treatment options she wanted going forward, including surgery or infusions. And she opted to have infliximab, which was another potent immunosuppressant given via infusion. And she did really well on this treatment and continued her treatment every 8 weeks. She then became pregnant and came back to see us to discuss the implications of her disease for her and her baby, but also the treatment for her and her baby. She had an uneventful pregnancy, fortunately, and then continued to see us for reviews of the extraintestinal manifestations of IBD and to discuss things like colorectal cancer surveillance, which is important in inflammatory bowel disease. And these are just the markers of when she saw us for her planned reviews and when she saw us for her unplanned or emergency reviews. And what I really want to get across on this very, very busy slide is the long and complex journey for patients with inflammatory bowel disease. And that brings me really to the service requirements. So as we saw from Sinead, she met her GP. She then met the IBD multidisciplinary team. So the complex involvement of lots of different individuals. And with those appointments, we also discuss access to diagnostics. So we need access to endoscopy, bloods, imaging. We need access to nutritional support with dietitians. There's a very high incidence of depression and anxiety in inflammatory bowel disease. So we need support from this in the community with the GP, but also with psychology. and obviously the impact this has on people's social and work performance and support for that, again through the GP and the IBD MDT, but also through things like the Irish Society for Crohn's and Colitis. And at each of these interactions, we have a variety of different treatment options again. So medications, infusions that are provided in the hospital, injections that are provided in the community, surgery and psychology. And again, what we're seeing here is an interaction between primary care and secondary care with the patient at its centre. And if we look at the roadmap again, we note that this has to occur at planned regular intervals, but also to be available in emergency situations. So giving, again, complex service requirements. I probably should call this the international standards because the main standards that we reference are the British Society of Gastroenterology and the NICE guidance, and also the European Crohn's and Colitis Organisation. And they publish, the BSG, for example, published their most recent ones in 2019, and they publish really detailed guidance about what this IBD roadmap should look like, down to kind of how many gastroenterologists, how many IBD nurse specialists, etc., that you need per head of population. So what's the impact of that for us in Ireland? Well, we don't actually have our own figures, so we think we have approximately 40,000 patients with IBD in Ireland, with estimated annual costs somewhere in the region of 259 million every year. This is largely driven by high-tech medications and hospital admissions, and it doesn't take into account all the indirect costs, such as time lost off work. If we look at our own local service, so in St. Vincent's, we have about 4,000 IBD patients, actually more. And if we look at the gastro service that we provide, so IBD is just a portion, now this is not an absolute representation, but it's a portion of the gastro service. We also need to provide care for patients with irritable bowel syndrome, celiac and other malabsorption syndromes, and cancer diagnostics. But if we are to provide care in accordance with the national guidance for our IBD patients, that actually takes up 103% of all gastro appointments. So something just has to change. So that's where e-health comes in. And as the previous two speakers really eloquently discussed, so e-health is about using digital technology to provide health services. And there's a huge variety in that. So, for example, virtual clinics. I first had my encounter with this in Perth. So Western Australia is an absolutely massive state. And we were organising appointments for people who lived 5 hours flight away. So obviously you couldn't ask people to fly down to see you to just tell you they're fine. And that was all done on video in their local health centre. And obviously we have lots more in terms of telemedicine and web-based applications, but also social media. And what I specifically want to talk about today is my own experience with MyChart. So in Cambridge, we had an electronic patient record known as, or powered by Epic. And as part of that, there was an electronic patient portal called MyChart. And what that allowed patients to do, and this is actually a screenshot from my own MyChart, so what that allowed patients to do is to view their own data. So in visits, they could see their clinic letters, their appointments, they could see all their test results, so all their blood results were available to them. For Sinead, for example, as she came, she saw her mesalazine blood post results, she saw her endoscopy report, her CT scans or MREs, whatever she needed was in there. There was also medications. So for example, if the GP started the patient on a new medication, Sinead could then enter that into her medication record, which I could also see. So she could suggest updates to her own information. And that really improved not just the communication between the patient and myself, but between primary and secondary care. And that was just the very basic platform of MyChart. What it also then was allowed to do as kind of the second iteration was communication. So patients could message their healthcare team. And they could also complete symptom scores that were then identifying problems that they wished to discuss at their next visit, again, tailoring the patient's appointments to their own needs. And finally, they had an option to share everywhere. And this became really important, what we saw during COVID, because for us in Cambridge, we had a lot of students that then returned elsewhere, and they had new community healthcare providers that they could then share all of their information with these new providers. And post-COVID, when we start to travel again, this will also be important. And if we go back to our patient journey, we can see that Sinead could use this information to see her appointments, to view her colonoscopy results, in her interactions and her appointments with us, to see her test results. So it can be used at every single point of the patient journey. And how did patients feel about this? So when we look at patient engagement, it was first, this is just for gastroenterology, so when it was first launched in 2016, we had 100 patients, and the number exponentially increased. And while these are old figures, I can tell you by 2020, we had over 1,000 patients in gastroenterology alone. And how did patients feel about it? So we asked our patients a variety of questions, but just these two. How useful did you find being able to contact your care team? And we found that over 85% of people found it either useful or very useful. And how useful did you find it being able to view your results on MyChart? And almost 90% of people finding it either useful or very useful. And I just wanted to talk through a case to show the very basic functions of MyChart. And this is a patient of mine, Daniel, a 24-year-old man with Crohn's disease. And in the pre-MyChart era, he contacted my secretary to say he was feeling unwell and could I call him back. So I tried to call him back and I got his voicemail. And then I couldn't really remember what the GDPR rules were about voicemails, so I didn't leave one. So I tried calling him back again and I still couldn't get him. And then I had to go back and document all this in Epic anyway. And how do you document a telephone call when you can't get the patient? And then I'm really frustrated and I still can't get hold of him. And eventually I just write him a letter to say, I can't get hold of you, can you please come see me? And I'm rather frustrated at this stage. And then I see Daniel in clinic and he's unwell and he's unhappy and I'm unhappy. And the whole experience is really just dissatisfying for everybody. So we fast forward a year and he sends a MyCharts message on the 4th of September. This is routed directly to the IBD nurse team, to the in-basket there. We've got a really fantastic team. They're trained to realise that the problem that he has can't be resolved over MyChart, so they arrange an appointment. And then Daniel confirms on MyChart that he's received this, and he sees me in clinic on the 9th of September. No treatment is required, and overall this was just a really speedy, efficient, and much more satisfying approach. And while this is about an IBD patient, this is not specific to IBD. This is a system. And this system can be transferred across to any patient anywhere in the world. In terms of rolling out functionality, so that was just a really basic thing that we did with inflammatory bowel disease. So what else could we do? So infliximab, as you may remember from Sinead, it's a potent immunosuppressant. It's a very effective but very expensive medication with lots of potential side effects. And it's given every 8 weeks approximately in hospital, and something we need to monitor very carefully. So before MyChart, what used to happen is the admin team would identify who's coming in for their infusion, and they would then drop down a paper questionnaire. The infusion suite nurses would give out this paper questionnaire that the patient would then complete. The IBD nurses would then go down to the infusion suite, pick up all of these pieces of paper, and huge stacks would just sit in their office. Some of them, most of them I hope, were eventually reviewed by the IBD nurses and occasionally entered into the patient's electronic chart. So what we did with MyChart is we developed the disease activity score, but we also included a patient-reported outcome measure to allow the patient to feedback more about their own feelings about their disease. The patient gets a reminder on MyChart to complete it, and they fill it out electronically on MyChart before their infusion. And actually, this comes back to Helen's point on the tsunami of information. So we actually set a threshold on disease activity, or if the patient signaled they had a concern, that an automatic message was created and routed directly to the clinical nurse specialist. So flagging anybody that was in trouble in terms of disease activity or that they themselves had a concern they wished to discuss. All the other questionnaires were then routed to the patient's chart and available in the synopsis section. So when I went to see or review my patient, either virtually or in person, I had all of the data that they had completed before, which is obviously invaluable clinically, but also from a research perspective, this is a real gold mine as well. And we presented this data at a European Congress earlier this year. So when we did a service evaluation then to look at how is this working. So when we looked at just the IBD nurse time on the first pathway, so not incorporating the admin people, the infusion nurses, just the IBD nurse section, that was taking 637 minutes a month. And then afterwards, the whole process was taking 450 minutes. So we're seeing a minimum of 30% reduction in the IBD nurse time. In terms of additional outcomes, so when we looked at our infliximab patients, 104, so 75% of them were active on MyChart and 80% of them completed the questionnaire. 53% flagged either a high score or reported a concern. 64% of these concerns were addressed through MyChart communication alone. 30% required an outpatient IBD nurse review and 6% required an outpatient medical review. And the mean time to address a concern was only 6 days. And then if we look, compare the groups that filled in the online questionnaire in 2020 versus paper in 2019. So what we see here, it's the same cohort of patients, but they're filling in the paper questionnaire here, and they're doing the online questionnaire the following year. And what we see is that the number of planned reviews decreases dramatically, unplanned reviews remains the same, and inpatient admissions drop as well. Now, I have to say that this was just done as a service evaluation, so it doesn't include complex statistics that take into account confounders. So in terms of implementing something like this, well, first of all, the challenges. So, you have to have an electronic patient record. So we had Epic as the cornerstone for this. Fragmentation of services. So in somewhere like Ireland where you have lots of different people working on different services, that can be quite a challenge. We had Epic for everybody in the trust. You need full MDT buy-in. So at a hospital level, we had a hospital MyChart group that included, the nursing, clinical, admin, IT, patients. So there was a full stakeholder involvement at a hospital level. But then also within gastro, we had our own MyChart group as well that I led on. And again, that had, clinicians, surgeons, nurses, admin, IT, patients, everybody. And we did this every month initially. And we had to do education and training sessions to get people up to speed and confident with using this. And as Chris eloquently mentioned earlier, of course, with digital exclusion, we were working on this in Cambridge, but we hadn't put this fully together. But in terms of the wins, so the patient satisfaction was high. From safety side effects, when we looked at our infliximab patients, there were no adverse events recorded, including for the group of patients that were not filling in the questionnaire. In terms of nurse service utilisation, there was a significant reduction in time used for the infliximab assessments. In terms of overall service utilisation, there was a significant reduction in scheduled reviews and inpatient admissions. If we looked at cost savings, we didn't either do a full health economics evaluation, but the hospital-wide reported huge saving on postage. And also in our department, we saved 1 day every month for admin and in our admin team, just posting and stuffing letters. And I suppose the most important thing about this is its generalizability. So we started off in IBD. We actually rolled out to all of digestive diseases within gastro. And for the patients, if they were attending rheumatology and gastro and oncology, they had access to all of their teams from one portal and all of their results from one portal. And not even just within patient groups, the whole staff COVID vaccination program was rolled out through MyChart. So this is not just for IBD, this is for everybody. Just moving on quickly for the sake of time, I'm going to mention another initiative that we did was on home fecal calprotectin. So calprotectin is a marker of bowel inflammation. It's used in routine clinical practice to assess symptoms, assess response to treatment, and also for monitoring. So if we look at our patient Sinead, she would have been asked to do fecal calprotectin at many points during her patient journey. And traditionally, it's a very glamorous thing that goes on. We give a stool pot to our patients when they see us. They go home, they collect their sample, and they either drop their poo back into us or to their GP in some instances. Obviously, during COVID, that couldn't happen. We weren't seeing people face-to-face as much. So we used CalProSmart, which is a home kit that patients could do at home, and they got an instant result on their smartphone, which was also immediately communicated with us. And when we evaluated this, we found that 57% of patients indicated that the CalProSmart kit is easier than standard testing, but only 33% of patients in our hospital return the kit. And this has significant cost implications because we pay for every single kit that we use this way, and they're not cheap. So it'll be fabulous for a small group of patients, but it's certainly not ready for mainstream at this point in time. And lastly, then, new patient information evenings. So as with my patient Sinead, she came to see us in the clinic and had her MDT information session done face-to-face, and that couldn't happen with COVID. So we set up a newly diagnosed IBD patient information evening that was done over Zoom. So there was a talk from a consultant, an IBD nurse, a research nurse, a dietitian, a psychologist, and a local representative from Crohn's and Colitis UK. And that also gave patients a chance to ask questions on Zoom, but also privately in the chat function. And the feedback we got from that was really fantastic. So I suppose my concluding remarks, I hope I've shown now that there's several initiatives that are useful in IBD, but also applicable across many other areas. The prevalence of IBD is increasing, the number of expensive, complex medications we're using is increasing, and the way patients access healthcare is changing. So e-health is safe, efficient, possibly cost-effective. There's a lot of work to be done on that. And IBD is one of many chronic diseases that we can use e-health in. And to turn really to eHealth Ireland to say that having an electronic patient portal is really the cornerstone for future healthcare delivery in this country. And really we need a resilient health system with the patient at its centre. And I just want to finish up by saying this is not just for people who are tech savvy. So yes, I own a smartphone, but my solution for my IT solution is turn on and off the computer. So even though I led for digital innovation, I'm definitely not tech savvy, and hopefully people will understand that this is applicable for everybody. Thank you.
Thank you, Edel. That was there was just so much there in terms of the advances with the digital delivery, with that communication tool, and I'll have a question in a minute about where we are in Ireland. But I just want to go over to the chat box here with the question from Katrina Walsh. Is there a link between the specific inflammatory markers in IBD and site-specific brain inflammation triggering depression, considering the high prevalence of depression in people with IBD? So I think it's more looking towards your specialty in IBD.
Well, I guess there's a few different theories about depression and IBD, and one is inflammation. I don't think we have a specific to say if you have specific sites. So if you have small bowel Crohn's disease, then you'll be more likely to get depression. I don't think we have site-specific information on that, but we do have a lot of information to say that inflammation is driving depression and anxiety in patients in general, not just IBD specific. So you see it in rheumatology groups as well. And Trace Murphy, who I did some PhD work with, was really interested in inflammation and depression. So I definitely think there is a link between inflammation, not specific to IBD, but inflammation and depression. And then in terms of the gut-brain axis, we know from what Liam has talked about, there's a really important links between the gut and the brain and serotonin and other important markers like that. And we don't have enough evidence to say that the gut-brain axis is what's driving depression and this high incidence of depression in IBD, but definitely the theory is there.
Lots more to be researched in the area.
There is genetics as well, actually. Some early genetic evidence from IBS, more so than IBD, that there's overlaps between some genetic predispositions for depression, anxiety, and irritable bowel syndrome. So there is some also potentially genetic overlap there too.
Okay, thank you very much. And any more questions from the floor? We have. Anna?
I was just interested that you showed that your that you show results of scans and things through the My Epic or through the thing. And the timing of that, because obviously scans are quite complex, they can reveal information that's quite concerning, and usually we'd see them first and then show them. How did you time that?
So this is actually a lot of work I did with the oncology service on this. So it was decided at a trust-wide level that there will be I think it was initially 6-week lag, then decreased to 4-week lag between when the result was reported and when it was released on MyChart. So blood results actually, apart from tumour markers, were all released, tumour markers and STI screens were all released immediately to the patients without anybody signing off on them. But imaging results were released initially, it said 6-week lag and then 4-week lag. And when we discussed this, most importantly, I think with oncology, because obviously their concerns would be the patient gets a scan showing a nodule or something that's quite worrying. But we kind of felt, well, you should be talking to your patients within 6 weeks of them having a scan that shows something that is extremely detrimental to their health. And therefore, that's a reasonable time frame for you to be doing things. And if a patient is getting a result that you haven't had a chance to speak to them about, then you need to look at your system.
Thank you, Edel. And the question from Liam there.
Just a question around this improvements in security and how open the system is to hacking, and how much effort is ongoing with this part of it? Because I guess that's, given what has happened recently, that's something that's on people's minds.
So I'll just repeat the question. I think it's around security and the recent cyber attacks and how you've managed in terms of how open the system is.
Yeah. I guess there's two aspects to that. One is that we have banking apps on our phone. So if I'm happy to share my banking and all my financial information with people, then my healthcare information should also be secure in the same way. So that's one aspect. And the second thing was, because this is linked to Epic, Epic is a huge company with massive information governance, security resources that's also overseen by our own information governance in Cambridge. So there was 2 specific platforms to ensure information governance for this whole process. So I think, we were very confident that on our end, information governance was being upheld, and then from a patient, they needed to protect it on their own server in the same way that they would their financial information.
Okay, I have a quick question. How far do you think we're away from it here in Ireland in terms of our electronic patient records that we currently have now that you have transitioned back to St. Vincent's?
Light years. And no, well, we're actually, Rochelle and I have been putting proposals in to try and secure funding to do something very similar for inflammatory bowel disease and some of the neurological conditions. There's an epilepsy electronic patient record. So there is something happening in Ireland, and eHealth have done a wonderful job in proposing a strategy about how we might go about it. It is disappointing to see when you go onto the website, the progress report is pretty outdated, and it's supposed to be from 2018, and not a whole lot seems to have happened. And that's quite discouraging. But as I said, there are people, champions, making efforts throughout the country, and if we can put that together, I think it is the only way forward.
Yes, I agree. So we just need a few champions like yourself.
Not sure about
and
that.
And the rest of us who you are now enrolling. Thank you very much, Edel. Thank you.